Hey there, and welcome. I'm Anna Hartman, and this is Unreal Results, a podcast where I help you get better outcomes and gain the confidence that you can help anyone, even the most complex cases. Join me as I teach about the influence of the visceral organs in the nervous system on movement, pain, and injuries, all while shifting the paradigm of what whole body assessment and treatment really looks like. I'm glad you're here. Let's dive in. Hello there, and welcome back to another episode of the Unreal Results podcast. Today, we're talking about the fibula. Yesterday, I was working on one of my athletes, and I ended up taping his fibula to support some posterior glide at the distal fibula. And he was like, it's crazy how much that makes my knee feel better. Takes the pressure off of my knee. And I was like, is it though? Is it that crazy? Because the anatomy tells us it shouldn't be crazy at all. In fact, a lot of people's knee pain and knee, dare I say, dysfunction is driven by the fibula. And all the things that influence the motion at the fibula through our gait cycle, through our leg moving, our ankle going into dorsiflexion and plantar flexion. So let's dive in and talk about the fibula a little bit. As I was writing down some notes of things I wanted to cover, I was like, you know what? Let's just do a quick Google search and see what comes up about the fibula on the interwebs. And of course, I read the beginnings of some research articles about different ligaments that attach to the fibula. And then I read just the general Wikipedia page about the fibula bone and a couple other random sources. But what is fascinating, I'm always kind of fascinated at how things were named, or what the Latin meaning of the words are, and or Greek. So Latin and Greek are often where a lot of anatomy terms come from, and so I thought it was interesting. So the fibula is Latin. The word fibula is Latin for clasp or brooch. So like a safety pin, something that holds things together. And it was named that for how the bone looks. So the bone, I've got the bones here for those of you listening. You can see it on the old YouTube video. But, so the bones, the way the fibula attaches to the tibia, it makes that whole unit look a lot like a clasp, look a lot like a barrette or a safety pin. And so that makes sense. So the other interesting thing, the word peroneal, which is the name of the muscles around the fibula, but often, so in fact, actually, the peroneal muscles recently, in the recent history, were renamed the fibular muscles, which is kind of funny. But the word peroneal is Greek for clasp. So they're basically saying the same thing. Peroneal is Greek. Fibula is Latin, but both of them mean clasp. And the interesting thing too about that, if you were to not know your anatomy, if I were to just hand you those two bones together and ask you what it was, you might even tell me that it looks like it fastens something, right? It's a large fastener. And this is interesting to me because oftentimes when we look at the shape of a bone, the structure of a bone or a joint, it can tell us a lot about the function. This is actually a practice that I first learned in a Franklin method workshop. The teacher took the bones and passed them around the class, and some people go to those classes without having any sort of anatomy background, so the bones are like completely new to them, and you're asked to describe them and ask what to describe what you think they do. And actually, when I teach anatomy for the yoga teacher training programs that I do, shout out Yoga One in San Diego. If you want to come learn yoga and learn anatomy from me, definitely sign up for the yoga teacher training. Anyways, when I teach the anatomy to those students, I do the same thing. I hand out the bones and I ask them to describe what they see. And we talk about the function of the bones in that standpoint. The structure dictates the function. And so if we're thinking about that, the term clasp or brooch when it comes to the fibula makes sense because it's sort of, I don't want to say holds together, but it really does sort of fasten and help to hold together the knee, especially, but then the relationship between all the joints of the lower extremity. The fibula has a direct relationship to the ankle and foot, the knee, and the hip/SI joint. And so it really is sort of like the fastener that connects everything together. So I love that little bit of knowledge that I'm sharing with you and learned today because it just makes so much sense. So with that said, the other reason I wanted to share about this is when I was talking to my athlete yesterday about it and why he was like, it's crazy that it makes my knee feel so good. And I said, really, because of the anatomy, it shouldn't be crazy. Is funny to me how many healthcare professionals sort of write off the fibula, like poo-poo the fibula. Like somebody, will get an avulsion fracture of the fibula, from spraining their ankle, or just they'll sprain their ankle, or even like a hairline fracture of the fibula. And doctors and rehab professionals will sometimes be like, it's not that big of a deal because the fibula is only responsible for like 15% of weight bearing, like 10 to 15 percent of your weight bearing load. And so it's not as big of a deal as if you were to, like, say, break your tibia. And so at some point, the story became not that it wasn't important in weight bearing, but because it wasn't important in weight bearing, it wasn't important at all. And when people had pain on their fibula or injury to the fibula, it's sort of dismissed and not considered, especially not considered when we're looking at the knee joint, especially not considered when we're looking at ankle mobility, and definitely not considered when we're looking at the SI joint and the hip joint. And so that is my goal for today's podcast, is to like shine some light on the fibula and actually just how powerful it can be to restore normal joint arthrokinematics to that bone and the joints that it creates, because it is such a fastener, a clasp to the entire lower extremity. And not only is it a connector to the entire lower extremity like that, but it is a important piece of our rotational locomotive pattern. So the anatomy, I already showed you the bones, but in general, the fibula is a long, skinny bone. It originates at the top of the tibia, just below the knee joint. So this is why I think sometimes it's forgotten that it's part of the knee joint, because if you were to just look at it where it articulates with the tibia, it's much lower down than the tibial plateau. And so since it's not near the tibial plateau, we don't think of it as being part of the knee joint. But we're going to learn about the ligaments, and you're going to know that it is an important part of the knee joint. And then the rest of the bone is like skinny. It's pretty flexible. Kind of reminds me of like the flexibility of a rib in a sense. Obviously, the ribs are more flexible because they have a built-in curve. And whenever we have a built-in curve, that is a bone that's extra flexible. It's kind of like a strut in the car, a shock in the car. It allows for a little bit more shock absorbing capabilities. But the fibula is a lot like that too. Which then makes sense when we talk about its rotational mechanic. Because if we're going to have a bone that needs a lot of rotational force through it, it needs to be flexible. That is also perhaps why it's not involved in a lot of body weight loading, because if we were to combine compression and load, what happens to it? It will break. In fact, that is probably what creates a spiral fracture of the fibula, is when you combine the rotational component with the compressive component. So, funny how that works. The other end of the fibula articulates, also articulates with the tibia, and it makes up the talocrural joint. So, let me see if I can hold it. So down here, at the distal end, you see it makes up this crural joint for the talus to sit right in it, right? So it makes that mortise and pestle type of joint upside down. So mortise would be like this, and then the pestle comes inside there. So part of the fibula then also articulates with the talus in the ankle. That's why I think it is more mainstream that people can accept the role of the fibula as part of the ankle joint than anything else. And we're going to talk about that a little bit too. But before we move on to the ankle component of it, let's talk about the attachments to the knee. So up at the proximal head of the fibula is attached to the lateral collateral ligament of the knee, as well as the arcuate ligament. The arcuate ligament is like a Y-shaped. One of the branches goes to the popliteus, like the popliteus tendon. And then the other Y goes to the lateral horn of the meniscus. Specifically, I believe the posterior lateral horn of the meniscus. So the arcuate ligament is part of the posterior knee joint capsule. So it is directly attached to the knee joint capsule. It also has extensions that directly connect. The fascia sort of connects directly to the popliteus itself. So it's two sort of connections. And then a third to the popliteus and the knee joint capsule via the popliteofibular ligament. The popliteofibular ligament, the PFL, resists posterior translation and external rotation in the knee. So all of these structures are a big component of our posterior lateral corner of our knee joint. And this is a common area that can be injured with a traditional rotary stability injury that might even tear the ACL. And so, in fact, if you start thinking about it, it made me wonder, it gives me the question, are part of the reason for non-contact ACL injuries, perhaps, would it have led us back to a fibula that wasn't moving and a loss of the rotational control of the joint? Don't know if that's true, but it makes sense. So the other attachment on that proximal end is the lateral hamstring. So the lateral hamstring attaches here, and then obviously extends up into the leg to the ischial tuberosity of the nominate bone. So it doesn't have a direct effect on the hip joint, but it sort of does, because as we know, the hamstrings are one of our hip extenders, a synergistic hip extender. And then it's going to affect, definitely going to affect SI joint motion because of that pull on the nominate bone. So that proximal part, the lateral hamstring connection to the SI joint so if it goes lateral hamstring, attaches at the proximal fibula, goes up the hamstring to the ischial tuberosity, and then the ischial tuberosity turns into the sacrotuberous ligament. Sacrotuberous ligament is what then crosses us across to the other SI joint, right? The fibers, and then wraps us around our trunk into the ipsilateral, same side neck. That I described is half of the spiral line of our body. The other half is the part distal to that proximal head of the fibula, and that is the peroneus longus as it comes down, goes underneath our foot, and then the extensor digitorum longus as it comes up the other side. That creates, I believe that's the other muscle in that, but either way, those muscles, those long muscles of the leg wrap around the fibula and the arch of the foot. And this is that rotational pattern in our body that's transferred throughout our body. Originates actually more in the trunk than the legs, but vice versa, can do both to create our rotational locomotion. And so the fibula plays a very important role on our gait pattern and the balance of our arches, the rotation of our hip, the rotation of our trunk via the sacrum. So it's interesting, going back to what I talked about at the beginning, that people would argue that the fibula doesn't really matter. I would say that description of the anatomy tells us that it really matters. And so what we often see too is what? Like one of the most common injuries that we see with our clients is a lateral ankle sprain, a sprain of the ligaments that attach the fibula, the distal fibula, to the tibia, the distal tibia, and to the talus and to the calcaneus. And even sometimes the cuboid bone and the other tarsal bones of the foot. So often though, when people roll their ankle, people are like, no big deal, just rub some dirt on it and keep going. And if you look in the literature for like studies on back pain and a lot of more of like chronic things, arthritis in the hip, arthritis in the knee, one of the like main factors that leads someone down that path is actually a history of an ankle sprain, specifically a history of an ankle sprain that was not rehabilitated. So in every single lateral ankle sprain I've seen, the fibula has been displaced anterior. And in fact, Mulligan, Brian Mulligan, I think is his first name. He is a physio out of Australia or New Zealand, down under somewhere. And he's most famous. So he's most famous for like spinal snags and nags, like a type of mobilization with movement. Same thing, like that's who first brought us like mobilization of movement for the hip joint with the like seatbelt. Those are Mulligan straps, Mulligan mobilizations. And he proposes in his book, by the way, which is like one of the best books. It's a really small, quick read, but it's packed full with great clinical information. So if you've not read it, I'll link it in the show notes, because I feel like every physical therapist, every athletic trainer, sports healthcare provider should really have read Brian Mulligan's work. So anyways, he proposes that even grade 1 ankle sprains, the grade 1 ankle sprains that don't really have a lot of tissue disruption in terms of like true spraining of the ligaments, is a subluxation of the distal fibula, and it gets stuck in that anterior position. So when we look at the joint, and I'm going back to the model here, when we look at the joint, when we dorsiflex, the fibula needs to posteriorly glide to allow the talus to shift back in the joint. If the fibula is stuck, it's going to prevent the normal motion that's happening at the talus, because not just posterior glide happens in the talus with dorsiflexion, but a rotation happens in the talus too. As we go into dorsiflexion, the talus needs to externally rotate as well. And if the fibula is stuck forward, it prevents that external rotation of the talus. And so therefore it can't glide all the way back posteriorly. And vice versa, when we plantar flex, the distal part of the fibula needs to move anterior. And that's what happens, right? The mechanism of injury of ankle sprain is often an inversion with plantar flexion. And so that can just jam the fibula up. And the fibula acts as a teeter-totter. So as one end moves, the other end has to move, right? Just like a teeter-totter, but vertical. So when the distal fibula glides anterior, the proximal needs to glide posterior, and the vice versa. When the distal fibula moves posterior, the proximal moves anterior. So you can imagine too, if the lateral hamstrings and the structures at the proximal fibula, all of those ligaments in the popliteus, are not functioning great, then the pull from those muscles are pretty strong, and it sort of locks the fibula from moving in that teeter-totter motion. It doesn't allow the proximal head to go anterior and inferior very well. So everything is sort of connected in that way. One of the main things I see that limits ankle mobility is when the fibula gets locked down and the entire lower leg gets sort of stuck in external rotation. And when that pattern is present, I almost always see some sort of limitation in the tib-fib joints, the proximal and the distal. And so it's a matter of playing around with anatomy and figuring out where it's coming from. So it can come from that old history of an ankle sprain. Any swelling in the area really jams that bone up too. It just right? Because when they're swelling there, I always tell my athletes the swelling is kind of like glue. It sort of gets really sticky. And if you're not good about moving through it and getting the swelling out quickly, then it just sort of like bogs down the movement of the bones and everything around those joints. And then two, the proximal tib-fib joint and popliteal connections, if anybody is like post-rotational injury. So for me, for example, I have a lot of posterior corner problems, and a lot of my athletes who have had ACL tears, even if they're repaired, still have some rotational instability at that true knee joint. And so this puts a lot of strain on the popliteus and those ligaments to function well. And then the proximal tib-fib joint is also what Jean-Pierre Barral refers to as a witness to visceral issues, specifically visceral issues in the urogenital organs. And so oftentimes when there's a visceral issue, it gets reflected down there and locks up that joint. Part of this is the relationship between the viscera and the SI joint, and then the SI joint innervations. I believe this is exactly what creates that witness, is that the viscera gets irritated. That message is relayed via the obturator nerve to the SI joint, because the obturator nerve innervates the parietal peritoneum. Also, some of those urogenital organs have innervations from, like the ligaments have innervations from the sacral plexus, and the sacral plexus and the obturator nerve innervate the SI joint along with the lumbosacral trunk. The lumbosacral trunk turns into the sciatic nerve, which is the tibial nerve, and the common peroneal nerve. The common peroneal nerve is the nerve that innervates that proximal tib-fib joint. And so when that nerve is irritated from something else, it can lock down that tib-fib joint and create issues. So another common thing, and it becomes chicken or the egg, is it locked down proximal and stuck in external rotation. So then you're not moving through your ankle joint correctly. So then you're not using your flexor hallucis longus, or because your flexor hallucis is longus, because it's just is weak, because it's weak, does it tighten up and hold the whole leg in external rotation? That is a pattern I see too, because the flexor hallucis longus goes from the big toe underneath the arch and the medial side behind the medial malleolus, but then crosses underneath the Achilles over to the lateral side and attaches to the sort of in between the fibula and the tibia in that deep posterior compartment. And so oftentimes when the flexor hallucis longus is tight, it also pulls the whole lower leg into external rotation and locks up that fibula. So again, going back to the original like term of fibula and peroneal, the word, the fastener, or sorry, clasp or brooch, this is again why, it's seen as a lock. It's like the same thing. And this is what I see with mechanics in the ankle, in the knee, in the SI joint, is if the fibula is locked and not moving, right? If the fastener is closed, if the clasp is closed and not able to open, there is effects up and down the chain, or it's closed because of effects up and down the chain, both visceral, peripheral nervous system, and then mechanical old injuries, right? So what do we do about it? Besides just knowing that it is there, my favorite things to do is first obturator nerve glide. So in case there is a visceral issue, I'm going to influence it. So obturator nerve glide, and then again, I'm always rechecking motion if it changes or not. And I have a video on Instagram that I'll link in the show notes that sort of shows this process so you can see it in real time. Sometimes I will do a tibialis anterior like self-massage in the area of that proximal tib-fib joint. This is really good. It's a common entrapment site for the common peroneal nerve, so that can be helpful in that area. Then I will do sometimes a common peroneal nerve glide. So again, just targeting that proximal tib-fib joint. But the common peroneal nerve glide, it also sort of targets some other things along the way. And then after the common peroneal nerve glide, I'll do lateral ankle tilts. Lateral ankle tilts are really good to open up the distal tib-fib joint, which sometimes is what unlocks the proximal. And it's interesting because the lateral ankle tilt I got from my friend Missy Bunch, who's trained in Z Health, and they use that drill specifically for lateral hamstring issues. Makes sense, right? Because the lateral hamstring attaches to the proximal fibula. And then finally, once I get that bone to move doing all those other things, I will sometimes use the Mulligan tape procedure called the fibular repositioning tape job to, I don't want to say hold it into place because then we're just locked again, but to facilitate the motion that's sticky, right? And whether you believe the tape is doing something or not, that's on you. How I describe it to my athletes is it's kind of like me being able to do a joint move on you every step you take. Whether that's from a sensory thing or from actual mechanical thing, I don't care because it has the same effect. And hands down, it is the most favorite tape job for every single athlete of mine. Even when I don't think they need it, they love it. They want it. And so, who am I not to give it to them? Because it does make a difference. And just like my athlete felt yesterday when you put it on, for me, the relief the thing that changes is a bunch of pressure in the posterior lateral corner of my knee. And that is way easier to do, that tape job and these drills to get my fibula moving, than signing up and getting my ACL finally fixed to maybe fix my posterior lateral corner instability. So anyways, I hope this was helpful. Definitely threw out a lot of anatomy, but hopefully maybe this just has you wanting to go back, dive in and look at it. This is exactly what I do in all of my education courses, is we look at the anatomy in this way, and then how it relates to the viscera, how it relates to the nervous system, how it relates to movement, and then what to do about it. So I'll link a lot of those correctives. I hate that word. I hate using corrective. I'll link a lot of those drills for the fibula, unlocking the clasp of the fibula, in the show notes, and enjoy. Have a great day.